envision like a circumstance in which a Medicare auditor is like, you rated them at 2, but I feel like they should be a 1. You know what I mean? That's probably not going to happen. But it's nice to feel like if somebody were to question your assessment, you could say, I'm basing that off of the fact they're a fall risk according to the TUG assessment that I did. You can't really refute that, you know. And so there's several that are listed here. I personally think the best one for anybody to use would be a TUG, and especially this is a nice way for nurses who may not I think PTs and when we do an open aren't viewing the med rec as being as much in our realm of what we mainly want to be there for. Mm-hmm. And I would guess that nursing is probably similar in some of these functional questions. Mm-hmm. If you do a TUG assessment, which a TUG is just you have them sit in a chair, measure off 10 feet, tell them go, and you time how long it takes them to stand up, walk 10 feet, turn around and sit down. You can infer, you've got everything you need to rate them on all of the questions. If they stand up, walk, come back, you can pretty much get to you've got your answer to all of the ADL questions, even the med, and that will give you some more insight into the med question, because you may be rating them based off of how they verbally describe this to you here, sitting in front of you, but you didn't see them walk. And the TUG is really widely accepted as having a good cutoff score for establishing fall risk. So and it is in our initial eval assessment, the start of care assessment, under the environment safety section. If you have to activate it, it's inactive. But if you find it in that section, it's in the same one where the MAC 10 is. You activate it. It gives you the cutoffs for when somebody's a high fall risk or not, and it's, I think 14 seconds is what they have listed. So if they take longer than 14 seconds to walk 10 feet, turn around and sit down, they're a fall risk, which likely means they require supervision assistance during gait, either at all times or on level surfaces, and likely means that you're going to then apply that amount of fall risk to all these other grooming, medication, all the other questions. So I recommend that. It's not really something we're saying is a requirement, but I personally feel like doing a TUG is a nice, easy way to. I've remarked before that the longest assessment that a TUG took was 3 minutes one time, and I was just like, after a minute and a half, I was like, we can stop. Let's just bring the chair up, and she just kept going. She was just plugging along, and I was like, okay, 10 feet. We're taking 3 minutes here. So it really is like if you're thinking to yourself, man, I have like that med rec took forever. I've got all these other things. I can't fit a functional assessment into my assessment. I mean, you've probably got 3 minutes, and hopefully the patient will not take 3 minutes to do it. So some examples here. These are actual patients that I had that I rated incorrectly that popped in my head as just examples of patients that I missed the ball on. So I'll read these out, and we'll talk about where I messed up, and so you can kind of see. 53-year-old patient was diagnosed in May of 2015 with stage 4 lung cancer as well as a pulmonary embolism. She actually walked into her physician's office having, just for like a routine checkup, had no idea anything was wrong. And it turns out, bada bing, bada boom, she had stage 4 lung cancer and a pulmonary embolism that she just didn't have any idea of. So, and it's important to note that she was fine. She had no assisted device. She was 53. She was working. She was doing fine. And then subsequently, and just as a result of medication side effects, and one thing over kind of spiraling out of control, she her ability declined significantly over the last 9 months. And at this point, she was spending the majority of her day in bed. She lived on a second level of her home. Bathroom was in the bedroom, so she didn't have to get up and down the stairs for that. But she had several falls that were occurring when she was walking, which happened randomly when her legs just gave out. She walks to and from the bathroom holding on to her husband for assistance. She has a wheelchair she uses for transportation to and from appointments, which she can't propel herself. She has a tub shower with no grab bars and no shower chair, but her and her husband were very proud of the fact that she takes a bath with her husband, lowering her into the tub and then lifting her up out of the tub. So her husband helps wash her, lifts her up from the tub floor once finished. I observed her sit up, stand up, walk to the bathroom and back, all of which had her assistance from her husband. So I rated this person as, I think I rated the assistance during gait was a 3. She requires human assistance at all times. and I think transferring was a 1 because she could stand up with minimal assistance. Mm-hmm. And bathing, I forget where I rated her, but truly, I think we talked about transferring. She was very easily a 2 in terms of. They actually did leave the wheelchair next to her, so it's not an issue of her needing to walk to her transfer surface, but she needed physical assistance and an assistive device to stand up and transfer. So she should have easily been a 2 at transferring. Okay. For gait, I said she needs assistance at all times. However, what I didn't really take into account, her husband would walk her, and she was falling with her husband. Oh, okay. I mean, her legs would buckle, he couldn't hold her up, and she would just plop to the floor. And they'd said this happened like 2 or 3 times in the last few days. When he was walking with her, she would fall. Mm-hmm. So she really couldn't safely walk with human assistance at all times. She was not capable of doing that. The next rung down would be a 4, is somebody who's chair fast and able to propel themselves. She couldn't propel herself in the wheelchair. So she really should have been a 5. Even though she was ambulating, I should have rated her at chair fast and unable to propel herself, because she was walking, but not safely. I mean, if your legs give out, when somebody's holding you up, that's not safe. For bathing, she's not able to bathe at all. So this was a topic of debate with Claudia and I. And we
an elective in there for that.
Yeah, so we have differing opinions, and ultimately she said that she feels like it comes down to clinician judgment, and I feel the same way. Mm-hmm. You could argue that, so they were bathing her in the tub. He was picking her up and lowering her into the tub and picking her up out of the tub. If you can't picture what that looks like, it was not safe at all. So she should at least be at a 4. Couldn't participate safely in bathing, but can participate in bathing at the sink or commode, which she couldn't independently bathe herself at the sink or the commode. She did have a commode they could have sat her in. She couldn't have done it herself. She would have had to have help. So she should have been at least a 5 based off of that. My argument is, they were so proud of the fact that they were doing this, and he was keeping her going, mm-hmm. and they just were so oblivious to how unsafe it was. And Kathy Martin was here. She had seen this patient with me, and we both remarked it took like weeks of convincing them not to do this, to where I feel like I should have rated her at a 6. Totally dependent in bathing, because she and her husband didn't have the safety awareness to recognize how ridiculous this setup was that they were doing. So, yes, functionally she could have participated in bathing at the bedside commode, but they didn't have the safety awareness to know that's how they should have been doing it. So I feel like this patient should be a 6. And Claudia said that at the end of our back and forth, she kind of felt like that would be justifiable, to say that. Mm-hmm.
She wanted you to rate her higher?
She said that 6 was really for somebody who can't get, who's bed bound, and that's the way the wording is, and I would agree with that. But I think if you take into account the patient holistically, their cognitive ability and everything else, I think she should have been a 6. And again, I mean, we're talking about having if I had that discussion with a Medicare auditor, I'd feel very comfortable saying, look, this is the manual that CMS published.
You wrote it.
You tell me definitively. Yeah, you guys wrote this. You tell me definitively how that patient's not a 6. So, so then we'll move on to the next example here. My next patient was actually a pretty high-level patient. I don't even know why she got a total knee replacement, because prior to her surgery, she was doing not CrossFit, but like a similar type of high-level fitness routine. Even up to immediately preceding the procedure, she was still doing that. She had all kinds of half marathons and marathons that she had done. When I saw her, she had no limitations with her mobility, really. She didn't need an assistive device. She was not really a significant risk of fall. She had no pain in the hospital. I saw her on day 2 or 3 from the surgery. I watched her get up, walk between rooms without any kind of assistive device, and up and down the stairs. During ambulation, she appeared steady. She really didn't need even supervision assistance or verbal cues. She didn't need walking in the house. Standing up from the chair, as well as on the stairs. She did move really carefully and slowly, and she had a little trouble bending her knee on the stairs, so I did feel like it was necessary to stay close just to be able to put a hand on her. On the stairs specifically. She had no grab bars in her tub and no shower chair. When I asked her how she was going to shower, she notes that she had this little small circular plastic stool that she was going to sit on in the tub. And again, just to provide the extra back, I mean, it was not a good idea to sit on the stool. It wouldn't have held up at all. She would have fallen. I didn't see her transfer in and out of the tub. She wouldn't have had any problem with it, really. She didn't even need a grab bar. I said if she just had a grab bar here to hold on to, but really all that she needed was a shower chair. So we talked about not being able to rate somebody off of their ability to use equipment that they don't have. For bathing, she should have been, again, starting off at a 4. You know, she was completely, on the day of the assessment, completely unable to bathe safely because she didn't have the assistive devices necessary to assess that. The minute she goes out and gets a shower chair, she would have been independent, you know, with the use of devices, but she didn't have it currently. So now, here's where it comes to the clinical judgment piece. You could also potentially argue that she didn't recognize that the stool was unsafe herself. So you could make the argument that, well, she should also be a 6 too. I had to intervene and tell her that's unsafe. She didn't know. So you could potentially make that argument. I would say the biggest difference to me is I guess I don't really know where the line is. If we take that into account, we're going to have a lot of 6s. We're going to have a lot of people.
Well, she could have sat on the commode and showered herself, right?
Yeah,
Safely.
she honestly could have just bathed safely at the sink. You know, the potential to say that she was a 6 would be based off of she didn't recognize that it was unsafe.
Yeah, that could be a
That to me is a little more of a stretch, just because she really wasn't overall very like unaware safely. I mean, she could easily just, you know, as I was like, you know, she was kind of like, should I do this? And I was like, I would just get a shower chair. That's not safe. Why don't you just use your wipes? So, you know, I think you could make the case that it was a 6, but given that it wasn't as much of a safety issue for me, a safety awareness issue, it was more just like she didn't have a shower chair. I think she'd probably be more of a 4. She was independently able to, you know, kind of use some wipes at the sink and whatever. But again, it's kind of open to interpretation. For walking, she wasn't using any kind of an assistive device in the house, but I, on subsequent visits, had seen her walk up and down the driveway and know that she was a little unsteady. I didn't see that on the day of the assessment, so the only thing I have to go off of is I saw her in the home and walking up and down the stairs. On the stairs, I did feel like, because it was still, her knee was tight and she couldn't quite get it easily up the stairs, I did feel like it was best to have somebody close. So she should have been rated at a 2. You know, she didn't need any kind of an assistive device, but she did require human supervision on the stairs. That's the second part of that question that everybody misses. So for ambulation, I would have said she's a 2. I think those were the, I'm trying to think of what other question I boxed with her. Why did I include her? So we talked about bathing, ambulation, transfers. I honestly don't really recall. She probably was a 1 because, and I probably rated her at independent with transferring, but she probably was a 1. She really was fairly steady, and if she just needed to push up off of something, could have stood up safely. But I mean, I honestly recall that going back, if I had watched her, thinking to myself that if she needs to push up off the armrest and also I just kind of don't quite feel that steady, she really would be a 2. So again, just kind of harp on that transferring point again. So you know, we've had questions all the time. Do you guys have any other specific questions about these items? This was solely focused on the 5-star rating questions. There's still, there's a 397-page manual that you could read that have the descriptions of other medication questions, other functional questions. So we're talking about this specifically because of the importance of these questions in the 5-star rating. It's the same kinds of guidelines that apply, and the conventions apply to all the Oasis questions. So, thinking about the complete task, thinking about the environment, the patient's total ability, not just their physical ability, thinking about medical restrictions, those apply to every single one of the questions. So it's important to think about it that way. It's also it's extra important when we have a Medicare patient, or if it's a managed Medicare patient, we're not sure if it's Medicare. It's crucial that we get these ones right, that we get them rated appropriately so that we can capture the improvement that we get. And some of them is just going to be spontaneous improvement. Like some of them, that patient who, the only reason they can't bathe safely is because they have a medical restriction. That patient in 2 days, without intervention, could go from a 4 to a 0. We need to capture those to balance those patients who naturally decline. Like some people are going to get worse. There's nothing we can do to stop that in some of these patients. But if we don't have that balance of, the patients who get better without any intervention, we can't, balance out the patients who get worse without anything we can control. So I know also personally I don't, I've never really valued the Oasis rating clinically. It doesn't make a huge difference to me if I rate them at a 4 or a 5. It's not ultimate. I'm not concerned about their movement of 4 to a 5 to a 1 on this assessment tool. So when I've gotten these kinds of calls from people saying you rated them too high or whatever, I've kind of blown it off, and I'm like, I don't want you changing my assessment because I just don't want you touching my stuff. It's important to be open to it because it is. I think we've harped on the importance of it enough, but it does. My view is if we can't show that we are a good company, it allows crappy companies to persist. I've worked for plenty of crappy companies that will call me on the phone and berate me into trying to get these questions to move. And I know, and I usually I'll give them no, I'm not doing that, and put my foot down. But I know other people aren't, and I know other people going, you can just do whatever you want, rate it however you want. And so people are, a lot of those ratings that you see that are higher, those companies potentially could just be the result of, bad practice, fraud, if you want to call it that. I mean, it doesn't necessarily capture that they're a better company clinically. To be able to balance that out, that's out there, to me, we have to be able to show that we're a good company so we can get access to those patients we don't have access to. So that's my soapbox 2 cents. All right, I think we'll cut and edit this and then submit it to maybe add some special effects.
Well done, John. You put a lot of time into that. Thank you very much.
Thanks.